Hi all, my name is Kyle. I'm joined by Haley and Ron to present our case to the Department of Justice and the Federal Trade Commission about the vertical integration of UnitedHealth Group and the United States healthcare market. I will start us off with a market overview, then I'll pass it to Haley to take us through the market analysis and some of the research that we've gathered to build the evidence in the case that we have to present to DOJ and the FTC, and then Ron will wrap us up with recommendations we have. To set the framing for our discussion, we're going to start with an example of a payer and provider market, just as we all know it today, and then what horizontal integration looks like in that market, which is sort of well documented, and then contrasting that with vertical integration and our thesis about these activities occurring right now in our healthcare market. Now, to baseline our thesis, let us start with an example. And in this example, we have several different payers that are competing in a regional market. UnitedHealth Group, Blue Cross Blue Shield, Aetna, Cigna, etc., all names that we recognize. And then we also have a provider market, in this case Caramount, Crystal Run, etc., names you might not recognize, but they are in fact real provider organizations, and they are all also competing in this same regional market. And in the first case, horizontal integration is the case where two of those providers, at least in this example, will merge together to form one large provider organization. And we do see some consequences of this, some benefits at times. For example, care coordination tends to improve in these circumstances, but we also see a lot of downsides where quality of care may remain neutral, but prices could increase, or sometimes quality of care decreases, depending on how you measure that. And Haley will actually discuss how we're measuring in some cases the quality of care. And it turns out this is not actually what we're studying for our thesis. It is a problem, but what we're studying is actually an exacerbation of that problem. So let's take, for example, UnitedHealth Group were to actually acquire that Megacare previously on the last slide, where they not only are experiencing horizontal integration through this consolidated Optum provider organization, but UnitedHealth Group also owns Optum. Optum is a wholly owned subsidiary of UnitedHealth Group. And this can have exacerbating consequences, where UnitedHealth Group can steer patients to Optum and amplify the effects of the horizontal integration through the vehicle of their vertical integration. And I previously mentioned this was just an example, but as it turns out, this is a real life case here in America. In this market in Hudson Valley, New York, UnitedHealth Group owned 30% of the payer market. But what's more alarming is that their provider organization owned more than half of the market share for providers in that same market. So you can imagine how UnitedHealth Group steering patients to an already disproportionately large healthcare provider in this organization could make that an even worse outcome for patients. And we find that this vertical integration mechanism is largely not as well noticed or understood by DOJ and FTC, which is the reason why we are predicating our thesis on this concept. And I will now turn it over to Haley to take you through some of the evidence that we've gathered to substantiate this argument. Thank you.
Thank you, Kyle. Now moving to the analysis. This analysis uses two main frameworks, accountability and quality of care. The accountability framework emphasizes consumer choice. In a competitive healthcare market, patients can switch providers, which pressures organizations to maintain high standards of service, efficiency, and patient experience. However, vertically integrated systems, such as UnitedHealthcare and Optum, limit networks. Quality of care is evaluated through factors like effectiveness, timeliness, access, and patient choice. When competition decreases, these indicators worsen. Two key stakeholders affected are patients and independent physician practices, especially in rural communities where provider options are already limited. For patients, vertical integration can reduce provider choice since insurers that own physician groups often direct care within their own networks. If patients seek care outside of those networks, they may face a much higher out-of-network cost. Concentrating patients can also lead to longer wait time and bottlenecks. Independent physician practices face growing pressure as insurers and large health systems acquire more. These integrated systems gain bargaining power and can negotiate better reimbursement rates. As a result, independent practices struggle to compete and will sell or close. The broader consequences of vertical integration in healthcare, focusing on UnitedHealth Group and its physician division, Optum Health. Optum has expanded rapidly and now employs or is affiliated with over 90,000 physicians, representing 10% of all physicians in the United States. Its control of primary care has also grown significantly, increasing by 2.1%, with some counties experiencing a market concentration above 40%. This growth is part of a broader trend of payer-owned physician practices, In 2016, less than 1% of physician practices were owned by insurers. By 2023, that number rose to over 4.2%. At the same time, rural healthcare access has become more fragile. Between 2013 and 2020, more than 100 rural hospitals closed in the US. And in some communities, the travel distance for care increased from 5.5 miles to 45 miles. While hospital closures are not caused solely by vertical integration, the growing market power can increase financial pressure on rural providers and make it harder for rural communities to maintain access. There are several real-world impacts of vertical integration involving Optum. Following Optum's acquisitions of Caremont Medical and Crystal Run Healthcare, 49% of patients reported difficulty scheduling appointments. 37% experienced longer wait times, and 33% were unable to see their preferred physicians. We also see broader disruptions in local healthcare markets. In Washington, 23,000 Medicaid patients lost their plan after Optum discontinued coverage. In Portland, one Optum clinic reduced from 10 physicians to just 2 within a year. Also, research shows that after Optum's acquisition, prices increased about 11% without improving quality. With these impacts in mind, next we will focus on recommendations to address these challenges.
Thanks, Haley. Now we're going to briefly review the impact and recommendations. I'd like to start with the Hippocratic commitment, which is basically to do no harm, committing to the beneficial treatment and avoiding harm or injustice. We're going to review HHI index considerations, FTC DOJ monopolistic oversight, and a novel idea which we call DOC, or the Department of Corporate Healthcare, and finally rural and population health. I'd like to start with the Herfindahl-Hirschman trigger. The DOJ has said that 1,800 is the limit for highly concentrated markets, and in an example where 4 health systems become 2 health systems, that number more than doubles. So it has substantial impact when a consolidation event occurs. As Haley mentioned, from 2013 to 2020, 100 rural hospitals closed, and with a sampling of 11 of those 100, the average travel distance increased from 5.5 to 44.6 miles. That's almost a tenfold increase for a rural population that's under immense financial and healthcare pressures already. And so this is where we feel the FTC and DOJ need to take a more proactive role looking at this and determining whether or not monopolistic tendencies are in the best interest of the market. Our idea for DOC, or Department of Corporate Healthcare, carries some similarities to DOGE, or the Department of Government Efficiency, in that it's a specific group of individuals that are volunteers, not financially compensated, that participate in overseeing and making recommendations to the executive branch of the government. The guidelines include transparency mandates for episodic care and CPT, relative market pricing, so annual selection of CPTs across specialties, so it's not a stagnant group of CPTs that can be gamed by any player in the market. Comparing statewide pricing deltas to see where we're going year over year, comparing statewide pricing to surrounding states to see where we're going relative to our states adjacent, and to demonstrate annual pricing improvement results to the executive branch. The organizational response we would recommend would be executive branch reporting. So to circumvent party politics, the executive branch gets this data and is allowed to use this data as necessary. Population health integrity scoring based on HHI and state market values, and then some level of veto or penalty power when health systems attempt to price manipulate. So our individual health systems recommended trigger for looking at systems would be HHIs over 1,800 to assess the market competition, but those numbers can be changed depending on the number of groups or hospital entities that fall within that system. Lastly, I'd like to bring up rural and population health focus or reforms that we think would be beneficial. So first, targeted financial incentives. Federal policies like educational loan forgiveness for PCP should be expanded to include all states with specific demographic needs, as well as practice loan interest subsidies for critical access areas in particular. Regarding independent tax credits, we think tax relief for new and existing non-corporate rural practice creation is helpful. And then the approval metric for these things would be a demonstrable HHI decrease. So in the event that a practice was created, if it fell under a large corporate healthcare system, we would not see a decrease in HHI. Therefore, you would not be eligible. And lastly, we would look at site neutral payment. So system analysis, integrated system pricing comparison versus independent practices to make sure that it's parity is found there. And then CPT dollars at differential sites within large systems. So are we paying a lot more for the same CPT at a hospital system or within the hospital itself versus an outpatient facility or of a private practice?